Good morning. This is Kathy Waldman with the Society for Pain Practice Management. I'm really pleased to introduce Dr. Ken Candido. He's a fellowship-trained, board-certified anesthesiologist specializing in the treatment of pain. He has educated hundreds of fellows, residents, medical students, colleagues all over the world. He's an authority on pain management. And in addition, he's an outstanding pain management clinician, and he's an expert in the diagnosis and treatment of complex pain problems. He's always been in the forefront of pain management, and he's trained and to perform the most advanced pain management interventional procedures. In addition, he's published volumes of articles, and he's participated in research on a variety of pain management topics. And when he's not immersed in the world of pain management, he enjoys his family and traveling, and he can also be seen throwing a football into a basketball hoop. So he's a man of many talents, and I'm pleased to have him on our program today and to be able to call him a friend. He's an amazing guy, and now I'm going to change it over to Dr. Candido.
Thank you, Kathy. I hope everyone can hear me. I hope everyone can hear me.
And Dr. Candido, if you can, there we go. I can see you and I can hear you.
Okay. Welcome, everybody, to this edition of the Society for Pain Practice Management 2024 course. It's a privilege to participate in this amazing society. And the Waldmans, Dr. Steve Waldman, Kathy Waldman, have been exceedingly gracious to me by asking me to participate year after year. I think I've got a 25-year history of doing something, one thing or another, for the society. One of my areas of interest and for which I have a passion, excuse me, is talking about opioids and the opioid epidemic, and also how physicians have evolved to do things to minimize culpability in terms of being blamed for patients who get into trouble with opioids, whether they have substance use disorder or whether they have an overdose problem and possibly even leading to death. And I'm going to talk this morning briefly about some of the historical vignettes associated with opioid use in the United States of America. But more importantly, for you who are prescribers of opioids, I'd like to go through the new rendition or iteration of the CDC's guidelines, if you will, for prescribing opioids, best practices, what we know going forward, what we knew in the past, and why things changed in approximately November of 2022. Most of you will recall that there was a guideline published and disseminated in about 2016, considered to be the rational use of opioids. And there was a lot of controversy associated with that. So a new iteration came forth in November, and I'll tell you a little bit about how that came to fruition and what that means for each of you who are clinicians, whether you're an MD, a DO, a nurse practitioner, somebody who manages acute and chronic pain, what the new so-called guidelines mean for you in your practice. Now, why do we need guidelines? Well, we're in the midst of a worsening opioid epidemic in 2023, 2024 than ever before. In fact, most recent statistics show that there were 112,000 Americans who died from drug overdoses last year. Now think about that for a second. Think about the magnitude of 112,000 deaths in this country. I live here in the Chicagoland area. Soldier Field holds about 60,000 participants for a Bears football game. If you filled up that stadium twice and eliminated every single spectator 2 times, that would be how many people die each year from drug overdoses. It's an incredible number, hard to comprehend, and it's been exponentially increasing over the past several years. So while some of you may rail against the concept or the prospect of using guidelines, in actuality, we do need some help in navigating the complex landscape of chronic pain and how we manage patients who are candidates for opioid use. I have no financial disclosures, by the way, over the last 24 months with any companies related to products. So in the past, prescription drugs were considered to be culpable for patients who sustained danger or harm or some type of adverse event related to opioid use. However, What happened about 10 or 12 years ago was that we realized that the statistics from the DEA and from the CDC were tainted. They were tainted because we didn't realize that fentanyl coming in across primarily our southern border, but also our northern border, manufactured in China, reconstituted in Mexico, and then disseminated through California, Arizona, Florida, Texas, for example, that fentanyl was the greatest killer of Americans more than any other compound. We've had 3 waves of opioid overdose deaths in the United States of America. You see that in the late 1900s, 1999 up to about 2005, the first wave was the rise in prescription opioid overdose deaths that started in the 1990s. Interesting, a movie from CNN called American Pain. I encourage you all to see it in your leisure time, about 2 brothers, bodybuilder brothers in South Florida, who started pill mills. And really, it's almost a caricature of what happened in the United States throughout the country, but it shows the gluttony and the greed and the misconceptions about what was the right way to treat pain going back in the 1990s. The second wave of opioid overdose deaths in this country happened in about 2010, and it was due to a rise in heroin overdose deaths. But by and large, starting in about 2013, the third wave, and the wave which continues now forward for the past 10 years in opioid overdose deaths, has been almost exclusively related to synthetic opioid overdose deaths, including drugs like fentanyl. Not exclusive to fentanyl, but fentanyl has been so cheap and easy to manufacture in a powdered form in China, and then to be shipped illegally, of course, across international seas to places like Mexico and Canada, where it's reconstituted. So we've had 3 waves. We're now in the third wave of opioid overdose deaths, and you can see that the deaths per 100,000 individuals has been exponentially increasing over the last decade or so. While physicians were largely given a lot of the blame for this, you can see that physicians took heed to the messages about opioid use, and actually opioid prescribing is down by some 20 million prescriptions per year in this country over the last 3 or 4 years. So physicians got the message. We didn't want to be blamed for patients who were misappropriating or misusing medications, and we had been scapegoated in many ways. It's a subject for another discussion. But by and large, over the last 3 or 4 years, you can see that prescription writing has been reduced markedly as physicians have taken into consideration that opioids are not the answer for most chronic pain conditions for most individual patients. And also you can see that things like naloxone use have been increasing also steadily over that same time period, as physicians realize that we have to safeguard our patients and keep them out of harm's way. In 2021, there were 107,000 drug overdose deaths. And when I say drug overdose, I'm talking about all players: opioids, benzodiazepines, hallucinogens, for example, methamphetamines. But opioids constitute a large percentage of those drug overdose deaths. In some statistics, over 75% of drug overdoses include one type of opioid or another. And now I've told you in the last year, it's up to 112,000 and counting per year with no end in sight. Adults 65 years and over had the largest percentage increase in the rates going from 2020 to 2021. So there is no gender or age or socioeconomic or race that is immune to the effects of opioid overdose deaths. The number of people who died from a drug overdose in 21 was over 6 times the number in 1999. That's an incredible statistic. It increased 16% from 2020 to 2021. And again, those 107,000 drug overdose deaths in 2021, at least 75% included some type of opioid, whether it was a prescription opioid or a street drug or the use of fentanyl, which we'll talk about briefly going forward. If you look here, we reached the 100,000 mark in deaths for the first time in January 2021, and that number doesn't seem to be slowing down at all. There are some people who are prospectively considering that by the year 2030, there'll be about 150,000 people dying from drug overdoses each year in the United States. It's an unprecedented, unparalleled type of statistic, which really everyone is doing their very best to try to get a handle on. and find the etiology as well as the solution for this exponential increase in drug-related deaths. As you can see from this statistic, about 75% of the nearly 107,000 drug overdose deaths involve some type of opioid. Again, prescription writing and prescription opioids, legitimate use of opioids, is a very tiny fragment or fraction of the actual number or percentage of deaths related to drug overdoses. However, you can see the age-adjusted rate of drug overdose deaths involving opioids by any type of opioid, and you can see that there's been a significant increasing trend from 2001 all the way to 2021 with different rates of change over time. But the take-home message is that while overdoses from heroin has stayed relatively stable, and while overdoses from natural and semi-synthetic prescription drugs has stayed relatively stable, what is killing Americans in droves is the use of pretty much synthetic opioids other than methadone. And again, fentanyl is the biggest player in that regard. By age, you can see that the number one affected age group for drug overdose deaths are individuals between the ages of 35 to 44. And you can see that males are represented to a higher degree than females. And this shows the rate of drug overdose deaths by selected age groups 15 and over, except for the younger age group where there's been a very slight decline, that is the ages of 15 to 24. The rates in 2021 were significantly higher than in 2020 for all age groups. And again, one of the most concerning age groups where there's been an increase in drug overdose deaths is in the 65 years and older age range. And for some reason, again, septuagenarians, octogenarians now are representing a significant proportion of individuals who succumb to drug overdose deaths. Age-adjusted rate of drug overdose deaths by sex, again, males are represented to a greater degree than females, and that's been relatively stable throughout many decades. Males tend to be using opioids, both prescription and otherwise, to a greater percentage than our females. Now, if you look at which types of people by race and origin, you can see that non-Hispanic, American Indian, or Alaskan natives have had a very substantial rise in drug overdose deaths, but also non-Hispanic, Black people, non-Hispanic, white people, Hispanic, they've all had a significant rise in drug overdose deaths in the last 3 or 4 years. So again, this is not a phenomenon which is exclusive to one race. It's not exclusive to one gender. It's not exclusive to one age group. And interestingly enough, this was actually a statistic which was published about a year or so ago. In the United States, the life expectancy has dropped down to 76.4 years, the lowest that it's been in a quarter of a century. And some people would blame the influx and the use and the deaths attributed to fentanyl as one of the main reasons why drug overdose deaths have changed our life expectancy. It's the lowest it's been since about the year 1990, which is a sobering statistic. Again, an estimated 100,000 people died over a 12-month period from April 2020 to 2021. That represented almost a 30% spike from the year prior. Interestingly, Vermont is the state that has the highest percentage rise, and nobody necessarily knows why Vermont has seen a 70% rise in drug-related overdose deaths, leading the country. West Virginia and Kentucky are next at 62 and 54.5% respectively, whereas states like New York have seen a modest rise of about 20%. And this is what the data shows. The data shows that all across the country, deaths have been on the increase between September 2022 to September 2023 for drug-related overdose deaths. Again, we're not talking exclusively about opioids here. We're talking about all drugs, methamphetamine, cocaine, benzodiazepines, other sedative hypnotic medications. But opioids are part and parcel to this statistic, up to 75% of cases. See that Vermont is up about 70%. Kentucky and Tennessee up past 50%. Louisiana, West Virginia also have very high rates of rise of drug overdose deaths. And we're doing all that we can, the DEA, the CDC, the FDA. But some of the limitations have been adverse to our patients. Remember that when the pharmaceutical industry was cited by the government and had to pay billions of dollars. One of the remedies from the pharmaceutical industry was to stop producing and manufacturing and selling opioids, to the detriment of our legacy patients and patients who actually require medications. The CDC guidelines, the original iteration of these guidelines was now about 7 years or so ago in 2016. And the scope of these guidelines, it was that it was intended for primary care physicians. And it wasn't really intended for interventional pain physicians or those physicians like us in this audience who manage both acute and chronic pain. And that was because primary care physicians didn't have specialized training in the management of chronic pain. They didn't know really how to look for telltale signs of substance use disorder in many cases, how to monitor patients using urine toxicology, how to look at the state prescription drug monitoring program. So the guidelines that came out in 2016 were intended for those types of physicians, primary care physicians, psychiatrists, family medicine doctors, internal medicine doctors primarily. And they talked about chronic pain, which was defined as that lasting for greater or equal to 3 months in duration. And so these guidelines were a little bit restrictive, however. And one of the recommendations was that clinicians should prescribe the lowest effective dosage. It seems intuitive and inferential, right? Why would we jump into a large dose for patients when we're initiating opioid therapy? But then what really caught the attention of individuals was that the Center for Disease Control suggested we should avoid increasing the dosage to greater than 90 morphine milligram equivalents per day, or carefully justify a decision to titrate dosages to greater than 90. So this number 90 became a rallying cry for all sorts of oversight agencies. They started to look at our prescription drug writing through the drug monitoring program. There were a lot of individuals who were taken to task if they were prescribing greater than 90 MMEs, and 90 became kind of a bastardized number. While there were some statistics to suggest that complications, side effects, deaths, morbidity, mortality were directly linked to MMEs, I think that people took this a bit too far, and so did the CDC. Now, the CDC was found to be erroneous in about 2018, tracking overdose deaths, which was found to be inaccurate. So the CDC actually and quietly acknowledged that the agency's methods for tracking overdose deaths were inaccurate, and that they overestimated the number of Americans who died from prescription opioids because they weren't factoring in the influence or the participation of fentanyl primarily. By stating this, after first alerting and scaring practitioners and patients alike that people were dying exponentially at an increasing rate, they finally had to backtrack and admit that their statistics were flawed. So in 2022, to be precise, on about November 4th, 2022, the Center for Disease Control in Atlanta, Georgia, came forth with their second iteration of the so-called guidelines for the prescribing of opioids by clinicians. They realized that the original guidelines often did not fit clinical scenarios. They also recognized that certain agencies were punitive or had weaponized the guidelines, again, strictly adhering to this somewhat arbitrary and capricious 90 morphine milligram equivalents per day. And physicians were getting in trouble if they were prescribing larger morphine milligram equivalents per day. And so the CDC, because of the outcry over this first iteration, they were encouraged to listen to actual patients, patients who have been suffering with chronic pain issues, patients who had been opioid dependent but not opioid abusing. And the CDC brought together more than 23 physician specialists to get a better handle on real life scenarios. And they actually this time relied upon peer-reviewed literature for making their formal recommendations. Also pointed out that these recommendations are voluntary, and that was one of the problems with the 2016 iteration of the guidelines for opioid prescribing, was that it felt that that was mandatory. No, clinician judgment was now put back into the driver's seat for determining which patients on an individualized basis might require larger doses and for a longer period of time of opioid use to manage their chronic, persistent, non-malignant, or in some cases, malignant pain. And so they also, interestingly enough, if you look at this, the guiding principles for the new 2022 practice guidelines, the government, the CDC, also fell into the DEI mindset, so-called diversity, equity, and inclusion. And their number 5 statement was that clinicians, practices, health systems should pay attention to health inequities. And this came based upon patient feedback and input. Also, they wanted to be inclusive. Also, they wanted to be diversified. So the government itself, paying careful attention to recent trends, became a DEI kind of weapon to make sure that we understood that the guidelines should be a DEI contingent type of practice. There were some concerns going back to 2016 that the opioid prescribing guidelines were inconsistent and had gone well beyond the recommendations. And that's why it now became up to a clinician judgment going forward in 2022 about how we use opioids responsibly and reliably for our patients who need opioids, both for initiation as well as for perpetuation. The guidelines also pointed out that 37% of all opioid prescriptions come from primary care physicians, again, family medicine doctors, internal medicine doctors, but not, and sometimes psychiatrists, but not by pain medicine clinicians or surgeons, which actually represent a smaller percentage of physicians who write for opioids for chronic medication use. Pain medicine and pain management specialists were not the focus of this clinical practice guideline, and that was emphasized in multiple places throughout the 2022 CDC guidelines for appropriate and effective and efficient and reliable opioid prescribing for chronic pain management. And so they recognize that people like us in this audience often have extensive training and experience with managing not just pain, but by the responsible use of opioids for managing chronic pain. Opioid therapy was associated with similar or decreased effectiveness for pain with other medications such as non-steroidal anti-inflammatory drugs. So what the CDC wanted to point out effectively was that opioids should not be the first line therapy for managing chronic pain, but that physicians and clinicians ought to do their due diligence to determine whether patients could be responsive to non-opioid analgesic medications. And so this was very important because the lack of evidence for long-term effectiveness of opioids remains very limited. And so the CDC wanted to emphasize to physicians to be aware that opioid use does not translate necessarily to improved functionality or to improved outcomes for patients who need opioids for chronic long-term pain management. And they also wanted to point out that there should be a plan in place for discontinuing opioids after extended periods of time. Although this could be challenging, that part of the long-term goals for pain management for patients, we have short-term goals and longer-term goals, should be some type of process in place to utilize alternative and competing strategies, including physical strategies, including sometimes interventional pain management strategies, but also non-opioid strategies, recognizing that this is a challenge and not all patients are acceptable to be considered to discontinuation of opioid use. The recommendations were essentially, the new recommendations from 2022 from the CDC were grouped into 4 categories: determining whether or not to initiate opioids for pain. Again, recognizing that there are alternative and competing strategies for managing most chronic pain scenarios. Number 2, selecting opioids. Again, rapid acting, short acting, immediate release opioids being considered to be the primary go-to opioid therapy for initiation at least, and determining dosages. Again, removing the language of 90 morphine milligram equivalents per day, which was found to be somewhat arbitrary and capricious, even though there was modest data in support of the fact that larger MMEs were associated with higher morbidity mortality. Number 3, deciding the duration of the initial opioid prescription and conducting follow-up. And how is that follow-up considered to be reasonable? Well, certainly not writing a prescription and then telling the patient to come back in 3 or 6 months. The expectation was upon initiation that patients would be seen, that the prescription drug monitoring program would be assessed, that urine toxicology would be identified and would be followed from the initiation going forward. Number 4, assessing the risk and addressing the potential harms of opioid use and educating and communicating this with our patients. Again, the onus was on physicians and clinicians to not just to address potential harms, but to educate our patients as such. The first recommendation of the new guidelines was that non-opioid therapies are at least as effective as opioids for many common types of acute pain, and that clinicians should be aware of this and should maximize the use of both pharmacological and non-pharmacological modalities, as well as using non-opioid therapies. So again, things like acetaminophen, over-the-counter local anesthetics, topical, transdermal, the use of non-steroidal anti-inflammatory drugs, that clinicians and patients alike should recognize that there are therapies that do not require the use of opioids at initiation. The second recommendation was that non-opioid therapies were preferred for both subacute and chronic pain, again defined as subacute less than 3 months in duration and chronic pain 3 months or longer in duration. Clinicians were encouraged to maximize the use of non-pharmacological as well as non-opioid pharmacological therapies, and that clinicians should work with patients, include patients in the decision-making process. The education, the communication piece was emphasized in many places in the new CDC 2022 guidelines. Third recommendation, I've already mentioned this, was that rather than going to extended release or long-acting opioid therapy, if opioids were deemed to be acceptable for use in your patient, that immediate release short-acting use opioids should be used at initiation, with the premise being that many patients, a substantial proportion of patients, would not be requiring long-term ad infinitum use on an ongoing regular basis of chronic opioid therapy. And the fourth recommendation, again, is intuitive and inferential, that when opioids are initiated, especially for opioid naive patients, that we would prescribe the lowest effective dosage. Again, that makes total sense, especially with the caveat being that, or the premise being that our intent, our goal is to utilize opioids in the lowest dosage for the briefest amount of time possible, while we find competing and alternative strategies for managing pain, including non-pharmacological therapy. Sometimes interventional pain management falls in that category, and non-opioid analgesics. Again, we've gone through what that constitutes: gabapentin, pregabalin, the use of local anesthetics, whether it's topical, transdermal, or by use of even oral preparations in some cases, non-steroidal medications, acetaminophen and related compounds, even acetyl salicylic acid, things which we commonly have available to us, but often overlook as first-line therapies. The fifth recommendation is that clinicians should optimize other therapies, work closely with patients. Patients had to be included in the decision-making process. And again, this was to have the patient be a steward in the process, to be a team member in the process, and take responsibility, take ownership for the decision-making process. Too often and too historically, I think clinicians had felt that patients should not be included in the decision-making process. The new recommendations and guidelines now encourage clinicians to optimize other therapies, but also include patients in the decision-making process at every step of the pathway, and gradually taper to lower dosages of opioids if warranted. The sixth recommendation was that clinicians should prescribe no greater quantity than needed. Again, it would seem intuitive and inferential, but this was a reminder to clinicians to be judicious, to be conservative, and not prescribe for larger quantities than would be deemed necessary or essential by the clinical scenario in front of the clinician. Seventh recommendation was that rather than see patients again after a prolonged period of time, that clinicians should evaluate the benefits and risks of therapies after a brief initiation with opioids when opioids are deemed appropriate. Again, within the first 1 to 4 weeks. That includes using things like behavioral identification, looking for risk factors, using opioid risk tools to assess for the susceptibility or the appropriateness of the use of these medications with our patients, urine drug toxicology monitoring, the prescription drug monitoring programs in your respective jurisdiction or state. And that's what the recommendation 7 was, that follow-up should be early and should be frequent on an as-needed basis. The 8th recommendation was that clinicians had to, before initiation and periodically during use or continuation of opioid therapy, evaluate risk, mitigate risk, including educating patients on things like naloxone nasal spray. Comes in 4 milligram dosages. Typically, one prescription delivers 3 inserts to a given patient. Patients had to be educated about where to maintain naloxone on their person or in their property, how to educate family members about what to look for in terms of signs of opioid toxicity, and how to safely administer, for example, naloxone nasal spray. The ninth recommendation was that, again, we've talked about this now several times. Almost every state now has a controlled substance prescription and monitoring drug program. I happen to be a member of the Illinois drug monitoring program for this state. It's fascinating to participate at that level and see how decisions are processed and how data is utilized to make rational approaches to monitoring both clinicians and patients. But all clinicians who prescribe opioids initially, as well as chronically, whether these are for acute or chronic pain situations, has a duty to understand and utilize their drug monitoring program and document the findings in that drug monitoring program for each individual patient, as well as what remedies are put in place when there are aberrant findings, meaning if a patient is receiving multiple prescriptions from diverse prescribers, what do we do? Do we have a policy in place in our practice about how to educate patients over this aberrant use, and what are the consequences to the patient and to the practice for allowing this to occur? 10th recommendation, of course, we've talked about this, was to appropriately use toxicology monitoring, and not just order toxicology. I can't tell you how many times I've reviewed patients' charts where clinicians have ordered drug testing, whether it's urine, whether it's serum, whether it's a hair sample, for example, and have ignored the results, or I should say more appropriately, overlooked the results. If you order a drug test, you are responsible for interpreting the results of that test and making appropriate clinical decisions based upon whether the findings are consistent or inconsistent with what is being prescribed to the patient. So it's not just acceptable to state, yes, we've tested Mr. Smith 6 times in 2024. If you don't interpret the results of that, well, you potentially put yourself in jeopardy or harm's way, as well as your patient. Recommendation 11 was to take great care and consideration before concurrently using benzodiazepines. And this is pretty much a hot topic, right? A lot of our patients have anxiety and depression issues. Many of them are somewhat dependent upon drugs like alprazolam, which is actually a terrible medication for pain medicine patients, as well as for any patient, quite honestly. Sometimes people are using clonazepam or sometimes diazepam. Certainly alprazolam is a substantial medication with very unique addiction risks. And so when clinicians are evaluating patients using benzodiazepines, great care and consideration should be taken before prescribing opioids. There is no such suggestion that opioids cannot be used, but the degree of vigilance, the degree of supervision may be at an increased level for patients who are concurrently using benzodiazepines, because we know about the synergistic risk primarily not only of addiction, but respiratory depression when benzodiazepines are used concurrently with opioids. Recommendation 12, when patients seem to have a substance use disorder, we have to identify it. How do we do that? We're not Sherlock Holmes, but we are trained to look for the telltale signs of opioid use disorder. Patients who are seeking early refills, all the red flags, they come in and they're asking for medication escalation. They state that they lost their prescription on the eve of filling it. It's Friday at 5 p.m. and the patient shows up and demands an early refill because they're going on vacation for 2 months out of state. There's so many things. History of cigarette smoking, for example, is a telltale harbinger for somebody who may have an addictive disorder. Family history strongly correlating with possible opioid substance use disorder. Sexual abuse, history of multiple accidents at work or motor vehicle accidents. All this information has to be elicited when you do your intake evaluation of patients before initiating opioid therapy. You have to be a good clinician, not just to manage pain, but to look for the telltale signs of opioid use disorder, and then to send the patient for the appropriate referral when indicated if that happens. Now, procedure-specific guidelines. Here's some interesting data from the Journal of Bone and Joint Surgical, because our surgeons, with the first 2016 iteration of the opioid guidelines from the CDC, they took heed. And so orthopedic surgeons actually were found in this retrospective analysis to have reduced opioid prescribing by 38%. So they took heed, orthopedic surgeons took heed to what was coming down the pike, and they didn't want to be cited for being out of compliance with the guidelines. And so orthopedic surgeons actually were prescribing less narcotics for their patients post-surgically. Neurosurgical patients also were found in 2021 to be prescribing less opioids to patients who had undergone spine surgery. So it wasn't just pain medicine or pain management clinicians who were prescribing less. In the post-surgical arena, both orthopedic surgeons and neurosurgeons performing spine surgeries were found to be prescribing less opioids based not on the new guidelines, but on the 2016 guidelines for patients having surgical procedures. Let's talk about a few legal issues. And of course, there are still outliers. When I say an outlier, clinicians, physicians, nurse practitioners, dentists, psychiatrists, sometimes who are prescribing outside of good common practice, and sometimes there are consequences to being a aberrant in terms of being a prescriber. And so what are some of the factors which influence the outcomes of investigations of clinicians practicing outside good common standards or judgment? And this was a nice paper published in Pain Physician in 2020 by Drs. Kim and Sabai, looking at the current state of opioid prescribing, as well as what the DEA has done in terms of actions against physicians, looking at data over a 13-year period. And so there are some commonalities. Having a DO degree versus an MD degree, an osteopathic physician versus an allopathic physician seems to be associated with a higher risk to clinicians for being cited for aberrant prescribing. Being male versus being female is another risk factor. Being in private practice versus being in an academic medical center, also associated with somewhat higher risk. Not having board certification has been noted to be associated with having higher risk of being cited for aberrant prescribing. Of course, the charges include things like possession with intent to distribute. Obviously, that's a horrific thing to be accused of, and the consequences to being cited as such are obviously very punitive. Higher rates of DEA action for foreign graduates, but that was of borderline significance versus those who are trained stateside in American medical institutions and osteopathic institutions. Interesting paper that I encourage everybody who prescribes to read. Have these legislations, have the guidelines, both 2016 and 22, have they worked? Well, sure. In 2017, there were 23.3 billion fewer morphine milligram equivalents prescribed or dispensed to patients on a volume basis, and also the actual number of prescriptions decreased by 10.2%. So in 2017, after the first iteration of the guidelines from the CDC, there was the largest drop in prescribing of opioids in the past 25 years. There was a 22% decrease in prescriptions between 2013 and 2017, and it was felt that this reflects the fact that physicians and other healthcare professionals are increasingly judicious when prescribing opioids, and that comes from the chair of the American Medical Association Opioid Task Force. So yes, physicians have gotten the message that we needed to do better. The economic burden of opioid use disorder, as well as fatal opioid overdoses, going back now some 6 years, has felt to be over $1 trillion. And actually, this is a sad statistic, $1.02 trillion, which reflects the economic burden due to reduced quality of life as well as death from opioid use disorder and the value of life lost. And so think about that. It's greater than the gross domestic product of most countries, $1.02 trillion. Now, the sad corollary or consequence of this is that, of course, the government looked at both the manufacturing. I'm not going to go through the history of Purdue Pharma and other companies that manufacture opioids, and they had to pay a stiff penalty and continue to pay stiff penalties to the government for participating in the genesis and perpetuation of the opioid epidemic. But this has been felt not just by clinicians, not just by the pharmaceutical industry, not just by the manufacturers, but sadly by our patients as well. It's been a trickle-down phenomenon, a domino effect of the economic burden being passed across from the government to the pharmaceutical industry, to clinicians, as well as to patients. And so how have we done now again, with things like urine drug monitoring, following the prescription drug monitoring program. Here's an interesting paper published by Sohn and Associates in Pain Physician 2021. It's found that even though we know that urine toxicology monitoring may be protective both to patients as well as to clinicians, it was found by this retrospective analysis of over a prolonged period of time that only about 50% of individuals receiving opioids, both for acute and chronic pain, were actually monitored using urine drug monitoring. And so this was suggesting that we've got to do better in terms of monitoring our patients. Even though there were over 2 million drug testing claims submitted, now the government is looking at the cost of this, because obviously there have been a lot of companies which have sprung up in the last decade or so, which have been mostly legitimate businesses, but sometimes not so ethical as well, overcharging patients for the drug monitoring, the cost of monitoring urine toxicologies. And so the government has been looking at this as well. This was a paper in Therapeutic Drug Monitoring published in 2021 that there's been a reduction in payment to some of these companies by up to 70% because of the fact that there was overbilling considered during the initiation phase of this. It was the Wild West when companies got involved in drug monitoring. The dollar signs were springing up everywhere, both for Medicare, Medicaid, as well as commercial insurance and workman's comp. Many times drug companies were charging $1,000 for simple urine measuring of looking for 4 different entities, sometimes $1,500, sometimes $2,000 for a single specimen, and it was found to be abusive. So let's go through some definitions. What is chemical coping? Chemical coping is behavior which bears a resemblance to addiction because pill taking is inappropriately used to manage things not related to pain, like stress, sleep disorders, etc. We've all had patients who say, yeah, I need these medications to function. I need opioids to be able to get up in the morning and go to work. I need medications to be able to maintain my household. But remember, we are not, as pain clinicians or physicians, we are not here to manage patients' stress, anxiety, or depression. We're only here authorized and trained to manage their pain using chemicals. So what are the risk assessment tools that we have available to us? I encourage you to look at some of these and to implement one or more in your respective practice. I like the opioid risk tool. It's a very simple number of items, only 5, and the patient themselves can complete this in the waiting area during their intake. Other things like the screener and opioid assessment for patients with pain, known as SOAP, are other tests. You should look these up. The CAGE test for alcohol use. You need to look for not only red flag behaviors in your patients, but how to assess them using these tools. So what is the opioid risk tool? It's very simple. There are 5 parameters, and a little bit different how we grade this test for males or females. It's done on the initial visit prior to the initiation of opioid therapy. So there's a family history of substance abuse, whether there is for alcohol or illegal drugs or prescription drugs. That carries different weight for both male and female patients. Is there a personal history of substance abuse? And I recommend to you, when you initiate therapy with your patients, regardless of whether you use a formal tool like the ORT, you must ask your patients, have you had a history of alcohol or substance abuse? Have you been treated for a history of alcohol or substance abuse? Not doing so, I believe, can constitute some negligent behavior. Also, the ages between 16 and 45 constitutes a risk factor. History of pre-adolescent sexual abuse seems to be a higher risk factor for females than for males. Again, these are tough questions to ask patients, but they should be considered. Also, psychological factors should be considered. We'll go through some of them as well. SOAP test, screener and opioid assessment for patients with pain. Another type of test to assess patients before initiation of therapy. Pardon me. What about the molecule? Well, there are certain chemicals like buprenorphine. Kathy, you still there?
Yes.
I need to take a 2-second break. Can I just interrupt for 1 second?
Yes.
Okay, put me on hold for 1 second.
Okay, we'll just leave this screen up.
Kathy, are you there?
Yes,
We can start again.
and I can hear you.
Okay, I just had to take a quick 2-second break to get a sip of something. My throat was getting really dry. Sorry. Ready?
No, nope. Yes.
So what about the molecule? What are some of the better, safer alternatives to conventionally used Schedule II medications? We should consider buprenorphine. It's been around for a long time, at least since 1981 in parenteral form. Buprenorphine is an amazing chemical. It's a synthetic opioid derivative of thebaine with very high potency. And while it's a partial agonist at the mu receptor, it actually has a higher affinity for the mu receptor than things like morphine. It binds more tightly than other opiates or opioid agonists or antagonists, and has very slow dissociation from the receptor with mild withdrawal. Interestingly, studies have been conducted in recovering addicts to determine the likability factor of buprenorphine compared to other Schedule II medications like morphine or hydromorphone or hydrocodone or fentanyl. And it's found that buprenorphine has very little good effect with subjects who are only modestly or moderately interested in the product. They don't choose this over placebo, in fact. So buprenorphine is a drug with very low risk potential for abuse. You can see that Buprenex was around since about 1981. I was privileged, along with Professor Alan Winnie, to conduct some of the early studies on the use of buprenorphine parenteral when mixed with local anesthetics for prolonging the effect of things like brachial plexus block. We did those studies in the 1980s and published a lot of research on this. But the most important for us as clinicians preparations of buprenorphine that are available are Butrans patch, which has now been around for about 14 years, indicated for moderate to severe chronic pain with a wide range of dosing, all the way down from 5 micrograms per hour up to 20 micrograms per hour. The beauty is that it's only 1 patch per week, so patients only have 4 patches per month. Belbuca is another buccal strip available since the last 8 years or so, again indicated for moderate to severe chronic pain. So buprenorphine should be considered to be part of your armamentarium. Very low risk of physical dependency and very low risk of analgesic tolerance compared to full mu opioid receptor agonists. It's also a Schedule III medication. Schedule III class drugs, which have been deemed to have less abuse potential than other drugs, including Schedule I, which we don't use, heroin, PCP, marijuana, and Schedule II, which we do commonly use. So consider buprenorphine use for your legacy or your chronic pain patients. I have tried to transition most of my chronic pain patients away from other Schedule II drugs to the use of Schedule III buprenorphine. We should finally consider psychiatric comorbidities, including substance use disorders, before the initiation or the continuation of opioid therapy for our patients. Why do we do that? Because there's a high prevalence consistently between some disorders, psychiatric or psychological disorders, and substance use disorders, things like bipolar disorder. Individuals with bipolar disorder have a 56% higher incidence of substance use disorder lifetime than other individuals who don't have bipolar. Cocaine dependency, ethanol dependency, all highly correlative to bipolar disorder. Prevalence and trends of opioid use in patients with depression, and anxiety are also correlative to a higher than expected, statistically significant prevalence of narcotic use. ADHD, again, highly correlated adult ADHD with lifetime substance use disorders, which is why patients need to be assessed for ADHD prior to the initiation or continuation of therapy. Axis 2 disorders, antisocial behavior, antisocial personality disorder, borderline personality disorder, all very highly correlative to substance use disorders. This has to be factored in before initiating or continuing the use of opioid therapy. Anxiety disorders, again, the prevalence or the co-occurrence of substance use disorder is 24%. And schizophrenia, of course, have a very high incidence of substance use disorder for alcohol, cocaine, and marijuana. And also, interestingly, about 80% of schizophrenics are dependent upon nicotine. What are my final recommendations? My recommendations are to look at the prescription drug monitoring program prior to the initiation of opioid therapy in your patient, as well as periodically. Urine drug toxicology at the initiation and periodically. Do not prescribe opioids at the first visit. Give the patient a chance to be assessed, evaluated, and to consider alternative and competing therapies for managing their pain. No benzodiazepines when possible. Certainly alprazolam is a drug of high concern. Screen your patients ahead of time. What does that mean? That means that you don't have to accept every patient referred to you as a pain medicine physician. If patients have a lengthy history or if they've been discharged from other practices, you should take this into consideration before making a determination whether the patient is appropriate for your practice. Use an expectation of care agreement. Most of us have these available to us. They're standard agreements. I think that 90 morphine milligram equivalents, while that's arbitrary and capricious, should be something to keep in the back of your head when initiating therapy or perpetuating therapy. Ask about withdrawal for your patients. Have a plan in place for competing and alternative medications. Ask about alcohol. Use the CAGE survey. Also educate your patients about the responsible and reliable storage of their drugs, as well as not to share their medications with their family members or neighbors. Also consider the use of structured approaches in psychotherapy for patients at high risk. And avoid, of course, methadone. It has not been found to be a good medication for long-term chronic pain. Now, I would be remiss if I didn't mention the tragic case of Dr. Todd Graham, because it's a stark reminder of the risks that clinicians face all the time when we use opioids. Todd Graham was a physical medicine and rehab doctor practicing in Indiana, my neighboring state, and he had a patient, a female patient, who had chronic non-malignant pain of an orthopedic nature referred to him. And Dr. Graham, on the first visit, refused to prescribe opioids for this patient. Well, the husband became irate and followed Dr. Graham out to the parking lot and ended up shooting Dr. Graham. So we run risks as clinicians, whether we do prescribe or don't prescribe opioids to patients. And we have to take care to safeguard ourselves, our practices, as well as patients when we are in this business of managing pain with or without the use of opioids. Finally, we must have some exit strategies for when things don't go well. So if we identify that patients are diverting medications, we have to notify law enforcement. If the patient has an addiction issue, we have to send them for counseling and consider medically supervised withdrawal, as well as using adjuvant agents for pain. The phenomenon of opioid-induced hyperalgesia, or OIH, is somewhat controversial. Consider that for patients who, despite escalations in opioid use, report ever-increasing levels of pain. Consider opioid rotation for patients who've had side effects related to their chronic use of medication. And I hope that this has been somewhat useful for all of you today. I have an email address, kdcandido1@gmail.com, if you have any questions or concerns and you want to delve into this any further. Protect yourselves, protect your patients, do the right thing. Prescription drug monitoring programs are very, very important. Urine toxicology, very, very important. And opioid agreements, very, very important. Good luck, safe travels, be well, and have a wonderful rest of the meeting. Thank you to the Waldmans and thank you to the Society for Pain Practice Management. Goodbye.